Okay, and welcome everybody to our final session of the day, where we have three speakers. This particular session is on using news across the pathway. I'm your chair for this final session. My name's Stephen Shorrock. And we have here today Dr. John Caldwell, who's the medical lead, Integrated Urgent Care Research and Quality Improvement, Primary Care 24. We have Dr. Matt Inada Kim, National Clinical Lead Deterioration, NHS England and NHS Improvement, and Thomas Knight, Clinical Research Fellow, University of Birmingham. So the usual format, we have three talks, and we have your Slido, where you can submit questions, and we'll have a Q&A at the end. So without further ado, I will introduce Matt, who will kick off this session, please.
Can you hear me all? Clearly at the back? I'll shout a bit. Apparently I was a bit mumbly earlier. So I'm here mainly to introduce my co-speakers. Thank you. What we've talked about over the past few days has been this concept of validating physiology at referral points across the care pathway. And it gives me great pleasure to introduce my other two colleagues who've done some astounding work in this area to try and answer that question for us, and really advance healthcare as it really occurs in real life, i.e. transitions of care from community all the way through to hospital. We've had a patient safety alert that dictates ambulances and acute trusts should move towards News 2. And as a group and as a body, 139 out of 140 acute hospitals are either there or doing so, and all ambulance trusts, so great stuff. And what remains is what we seek to do in the community to spread that. This validation of the same language in healthcare is a really important thing. It's an important thing not only in healthcare itself and the quality of care it delivers, but for the same human factors principles that underline why airline industries changed all those years ago, following the Tenerife crash, the KLM 747 that resulted in over 500 deaths. What's really interesting about, I suppose, that disaster from, a healthcare perspective was how many similarities there were. There had been a terrorist incident, there'd been diversion of flights from one airport to another airport. There were huge blockages, there were congestions on the taxi, on the runway. And every single time I read about that story, it makes me think about my own emergency department or my own ward and how stacked up against safety it sometimes becomes, and how reliant we are on verbal communication at referral points, and in the KLM case it was radio communications that led to the disaster. Following that, they moved to a standardized language, a checklist type approach to discussions between towers and the plane. And we are on the threshold of doing the same in healthcare across the care pathway in some ways, without that horrible 547 odd numbers dying. And although we'll never have the weight of those numbers dying in a single incident in healthcare, we must respond to what the evidence is probably telling us. I'm a firm believer that there isn't going to be a wonder drug that's going to sort the NHS out, or indeed the safety of healthcare. It's going to be the way we operationalize the pathways of care, the way we think about patients at risk, the way we hand them over and communicate about them, our reliability at doing vital signs, which is pretty low in some environments, our ability to transmit that and transmit our concern and worry in a reliable framework so that the person on the other end of the phone understands what we're saying. And it's going to be a change in that system that delivers the outcomes that we're after. And perhaps, if we can validate it, a single language of sickness might advance the cause more than anything else, and a single potential template for how communication should be thought of. With that, I'd like to hand over to my colleague, John Caldwell. It's green for next.
Hello, I'm John Caldwell. I'm a GP, and I'm not an academic. I've not done a great deal of work in that field before, but I've developed an interest over the last few years in trying to validate the work that we do in using news in our out-of-hours service. So it all starts with a patient story. This is a patient who came into our service. She was 37. She was normally quite well, and she rang NHS 111 with vague symptoms, pain in her legs, vomiting, feeling generally unwell, and was quite panicky and was breathing rapidly. There wasn't any significant past medical history, so our triage doctor took the story, decided she needed to be seen, and arranged an appointment in our centre. And when she was seen in our urgent care centre, she looked unwell. And there were a number of physiological changes that were recorded. She had tonsillitis with a good deal of exudate on her tonsils. And the doctor who saw her was quite an experienced GP. And he wanted to admit her to hospital, but she wasn't very keen on going herself. And he didn't really have the necessary tools to be able to insist that she go to hospital. So the diagnosis of acute tonsillitis, he gave her penicillin V. Off she went with her cousin to go to the chemist. And when her cousin came out of the chemist with the prescription, he found her collapsed in the car park. She was taken off to hospital, where she died of sepsis a few hours later. And we really do not want that to happen again. So we did an assessment of how often we actually took the observations in our patients who were sent into hospital. And we were shocked to see that it was only 11 or 12% of the time that they actually had a full set of observations that would have allowed us to calculate a news. Most of our GPs had never even heard of news. It came out in 2012. Those of you in hospital practice will be very familiar with it. GPs who've been out of hospitals since the last 10 years or so would certainly not have heard of it. So we thought that it would make a good way forward. We have got ourselves involved in a quality improvement program with Aqua, the advancing quality team in the Northwest, and we set up a driver diagram, and we decided that we would aim to get 75% of our patients who had an infection and we sent to hospital would have a news score calculated. So we did it. We used the PDSA approach. We thought about how we used the improvement tools, and we noticed even in the first couple of months that there was substantial improvements. We got a major colleague on board, Emmanuel Nasubi, who was one of Matt's colleagues as a clinical lead in deterioration and sepsis, and he came along and talked to our doctors and really helped us with that transformational change. So 12 months into the project, we actually managed to reach our 75% target. It was a bit after we'd aimed for, but we were told it was unrealistic when we were doing the original QI work. So we kept feeding back to our doctors the results, the fact that it was improving month on month, and giving them patient stories as well of people who had benefited from the change that we'd made. And colleagues talk to colleagues. A doctor who'd seen a patient who looked really quite well with when they came into the surgery in the middle of the night, she did a news score and it was 7 and sent him into hospital when she really wouldn't have done that without that validation. And that made a huge difference to her practice and meant that she talked to her colleagues and other people started to change. So these were our results this is over a 2.5-year period, and you can see that we're now maintaining our number of patients who have a news score calculated is in the high 80s now, 87% or so. And we've maintained that more or less over the course of the last year and a half. So we're really quite proud of the change in the culture of our doctors that resulted from this work. And our clinicians, we found they often did have set ways of working which weren't evidence-based. But as we're providing evidence, and we can provide evidence for other organizations to take up a similar approach and change, there are lots of preconceptions that are barriers to change, and the human factors involved in that process are complicated. So there isn't a single approach that works for a whole group of doctors. If you get 20 GPs in a room, you'll usually have more than 20 opinions about what you should be doing. But even so, you need that sort of clinical leadership, and you need the engagement of your board, and all of the people working for the organization can come along when there's that real drive and determination from the top. So we're also concerned that there might be an increase in admissions if we started to use news in primary care. And we're aware that the 4-hour wait targets achievements are worsening across the country. Emergency hospital admissions are going up, and the regional figures and all our local acute trusts are all reporting increases in admissions and increases in acuity. So we wanted to address that concern, and we've talked to our local hospitals about it. So they were our results for the number of patients that we actually admitted to hospital. The first blue arrow is where we started our sepsis project, and we introduced using news. The second blue arrow was the 17th of December 2017, when we changed to News 2. And as you can see, the trend line really has not changed at all. We were really excited 6 months after we'd introduced News 2, because we thought we've got a downward trend. But how much of that is natural variation, and how much is real is another matter. So we are sure that it hasn't increased the trend, and actually that trend line is lower than our local trusts, the 3 major trusts in our local area. So our current position is we are doing pretty well from the point of view of the raise in admissions. We really think that it's been a valuable way of improving the way that we can talk to our colleagues across the pathway. We now pre-alert our local ambulance service and our local hospitals if we're sending somebody in with a news score of 5 or more. We make sure that we get this consistency of observations going right through the service, and we train anyone who's new to the service in the use of news at the beginning as part of their induction to the process. There are lots of ways that you've got to keep the work going in order to maintain the improvement. We are in the process of doing further analysis of this data. We are doing follow-through work with our local trusts to look at morbidity and mortality data from the patients that we send in, so that we can try and prove that we are making a big difference to the results of the patients. So I've linked up with an academic collaborator recently, and actually it turns out that Tom, who is speaking later, will actually be working with him. So we can then get our work published in a peer-reviewed journal and get the information out there. So over to Matt.
So based on the huge amount of work that John has done and others in community settings, certainly for us in Wessex, we sent out letters to all healthcare professionals in hospitals and in community settings on behalf of patients, asking them to think about communicating physiology in the news score at referral points to try and improve safety. And there was the question of what the mortality was at each one of those ranges. And although the lines in the sand seemed pretty sensible, we needed the validation, we needed the evidence behind what that suggested. And although there were wonderful stories supplied by patients and GPs who used news on patients that are seen by different colleagues at different points of time, and tracking that deterioration and then making the right decision based on the physiology and based on the clinical judgment of healthcare professionals seeing patients, we needed something black and white, something hard and fast to validate our practice and what we were planning to do. And West of England did some great stuff looking at the qualitative studies of news in non-acute settings. And this qualitative work really helped create the groundswell of enthusiasm and support for a change in the way things are done. And what they were able to prove over time was that their mortality rates dropped as a result of their pan-regional implementation of News 2. We were able to see the same thing in the use of nursing home charts that actually looked at end-of-life care as well as communicating about sick patients across the care pathway. And in this project in the West Hants CCG, they were actually able to demonstrate a reduction in 999 calls and emergency call-outs to GPs as a result of implementing a News2 based format. There's around 25% reduction in GP calls, 35% reduction in 999 calls. And we were faced with this question. Yeah, that's all well and good, and the theory is wonderful, and there's some really good human factors elements in here that you're getting on top of. But actually, where's the validation? What does a high news mean in a general practice or community setting? And can it really be used to guide urgency or placement? Is there any value in news in community settings? And to answer that, we needed to go back to basics and think about the data sharing between our organisations, between general practices, the ambulance service, the hospital. A real honesty moment of thinking about patients in our region and thinking about how we were going to derive the evidence to prove one way or the other as to whether this was worth the effort. Physiology at referral points. And so we developed this digital take tool to try and answer this question, so that for every GP referral, we asked the news score at the referral. At every single ambulance conveyance, they asked the news score from GPs, from the hospital. And when they handed over patients, we asked for the news score to be done at every turn. And obviously it was a slow build in terms of that reliability. And we used that to try and prioritize patients, to try and figure out who the most sick was and who needed attention most rapidly. And it gave us this ongoing registry of all emergency admissions that helped us both in real time for real patients at any one point in time, but also an invaluable analytic tool for actually researching the validity of News2 in the pathway and actually answering the questions of what is really wrong with patients and whether processes and timings really make a difference. So now we've got over 35,000 patients in that registry, and it's building by about 30,000 a year. And soon we will have the machine learning database to, I think, answer the questions that really matter. It's a spreadable model of digital information that we hope to spread around the rest of England. And if we can create essentially a registry of badness for England, it will answer the question on what really kills our patients and what we as healthcare practitioners and systems leaders can do about it. Because it is a bow tie situation where you have your emergency admission, the deterioration admission that is the center of it, and you have the factors that precede it and then the outcomes that follow it. The factors that precede it included your genotypes, your genetic makeup, your environmental factors, your comorbidities, your disease processes, the drugs you take, your symptoms. And then at the knot, it's what happens to you when you become sick, and then the outcomes thereafter. And if you plug in millions of patients' worth of data, it gives you all the answers. If you can set up this sort of registry and the sharing of knowledge at scale, which can be done. And for us, that development of this EPR take tool allowed us to do this in a microcosm of patients at our hospitals. And this all enables this population level research. And this is what we're really excited about and what Tom's going to talk about. Into the physiology, that basic thing. Do vital signs really matter? What is the significance of a low blood pressure? Does it really matter? Why are you asking for all the observations at referral points? Why are you asking for the news at referral points? Can we prove, much like KLM 747, that the same language really does save lives? And can we use the take tool to essentially validate news across all settings? Over to Tom.
Lost my mic.
Green.
Cheers. Thank you, Matt. My name's Tom Knight. I'm an acute medical registrar in Manchester, but currently taken some time out to do a PhD in Birmingham University. And my key area of interest is acute care pathways, and particularly the interface between the hospital and the community setting. And that's how Matt kindly invited me to look at some of his data that he's developed from his take tool. So having worked all my time in a hospital environment, news isn't a particularly contentious issue for me. It's used ubiquitously across all hospitals and seems to be one of the things that stays the same as you move from hospital to hospital. And we're moving towards a consensus where every hospital will use the same news score. But even when there's slight variation, the fundamentals remain the same. A news score of 0 is quite comforting, a news score of 20 is quite scary, with different grades of panic in between. What Matt's already given is quite a strong argument about using the language of news scores to communicate risk. What I'm going to talk about is using this in primary care, where the use of news score isn't as well validated. And in order for us to use this more widely, I think we need the logical argument that says this is a sensible thing to do, but also some robust clinical data to say that a news score that's high in the community means the same thing as it does in the hospital, or at least a similar thing. And what I plan to do now is show you some data that I think shows that quite well. So the TAKE tool that Matt's alluded to collates all acute medical admissions to 2 hospitals within the Hampshire Trust. And I'm going to talk to you today about an analysis of 29,000 patients in total, really focusing on the GP referrals. So within the analysis, I'm going to talk about the roughly 7,000 GP referrals. There's 18,000 emergency department referrals and 3,000 referrals from other sources, clinic, repatriation. So within this data set, these are some characteristics of the patients contained within. And in terms of the GP data set, the ages are broadly the same, the same amounts of frailty, same amounts of dementia, same prevalence of advanced care planning, but the mortality differs. The mortality is much lower from GP referrals at both 5 days and 30 days, and there's a lower incidence of ITU admission. But beyond those simple descriptive things, the beauty of Matt's data set is the presence of physiological variables within. So there are about 18,000 news scores recorded within that data set, and they're split into 2 groups. There's news scores recorded on referral. That's a news score documented on the conversation between a referring clinician and the admitting clinician that's occasionally a doctor and more frequently an advanced nursing practitioner. But there's also news scores from ambulance data within that data set. There's a data sharing agreement where the first recorded news score by ambulance is recorded within this data set. I'm going to focus on GP referrals, of which there's about 1,800 news scores recorded on referral and 1,500 news scores recorded by ambulance. And the analysis is in 2 separate parts. For so most of the slides, you'll see graphs relating to those 2 sources of news score. So this shows the work that Matt's done within his hospital to increase the use of recording news scores on referral. So the data set goes over an 18-month period, and for the first 6 or so months, news score wasn't really recorded at all. Over the following 6 months, it started to be recorded more frequently, and it was noticed within the trust that patients that died had a higher news score, and this was prioritized locally, and it was taken up, and it was recorded much more frequently, to the point where over the last few months, over 90% of patients have had a news score, between 80 and 90% have had a news score recorded on referral, whether that's a referral from ED or general practice. There was a little dip in the early part of the year, which I wonder whether is related to new staff starting, but Matt gave them a bit of a kick and they started doing it again. So this is some histograms of the distribution of news scores within the data set. So this is the data set as a whole. As we can see, the news scores on referral are in blue and by ambulance are in orange. And the data is well skewed towards lower risk news scores. And this is also been shown in the national SAMBA audit that the vast majority of patients presenting as acute patients have low news scores. And this is true also of news scores from general practice referrals. The most common news score from an acute medical referral is 0. But news score certainly does tell us something about mortality. So this is a graph of the mortality as a proportion within the entire data set, with 5 and 30-day mortality shown in orange and green. So as you can, what I take from this graph is the very low rates of 5-day mortality at patients with 0 and 1 that increases incrementally to the point where when your new score is above 10, your mortality approaches 15% at 5 days and 30% at 30 days. And when we talk about mortality, age is clearly appropriate. So this is now mortality at 30 days with age above or less than 80 in orange and green. And as you can see, it's the same pattern with incremental increases in mortality as new score rises. And particularly striking is the really high mortality amongst patients with EWSs of 10 that are later in life. And I think this should really colour the discussions that we have with patients, both at the point of referral and early in admission, because the mortality is extremely high in this group. But where the data is lacking at present is specifically around referrals from primary care. So these are simple descriptive statistics of the new scores on referral and by ambulance from primary care referrals specifically. And this is age compared with 5 and 30-day mortality. The new scores are higher amongst those that die in terms of both their mean and median scores, and that's a statistically significant difference in new scores. But we can dig a bit deeper into the mortality. So this is a similar sort of graph of mortality as a proportion, with new scores on referral in green and new scores in patients referred by ambulance in orange. And again, we see this same stepwise increase in mortality as new scores increase, with a big jump between medium and high clinical risk, which is defined as an aggregate score of above 7. So if your score is above 7 and you're a GP referral, the 30-day mortality is high. Interestingly, in the ambulance referral group, the mortality is quite high even amongst patients that have a new score of 0 or 1. And I think that tells us more about the type of patient that might be conveyed to hospital by ambulance from a GP referral with an EWS of 0 and 1 and the presence of frailty in that subgroup rather than physiological risk. A commonly quoted outcome in the literature around new scores is a composite outcome of 30-day mortality and ITU admission, and we can see similar distribution within that group with this big jump in mortality as we progress into high clinical risk new scores with an aggregate score of above 7. And finally, when looking at diagnostic tests, some idea of discrimination using ROC curves is often quite useful. Now, with the 5-day mortality, we have an AUC of 0.7, which is quite a strong discriminator, but with quite wide confidence intervals. And I think over time, as Matt generates more data, death at 5 days from GP referrals is a relatively rare event, and I think over time we'll be able to tighten the confidence intervals around that prediction. So in summary, I think we've provided quite clear evidence that amongst GP referrals, mortality increases as new score increases. And this does provide, I think, put alongside the logical argument about using the same language, and this clinical data makes quite a strong argument for recording a new score at the point of referral. I think one of the common arguments often brought up against using new scores in primary care is using it in every primary care consultation, which is clearly not what this is evidence for. This is at the point of referral where the level of pre-probability of illness is already very high, and in that specific context, this is a very useful tool. And I think we've got a good argument to start using it more widely. Thank you.
Thank you, Thomas, John, and Matt. And we will now move over to some questions. So if we could have the Slido questions, please. Just before we start, I have one question of my own, which is, so I was a patient recently in hospital, and I was in an awful lot of pain, probably as much as I've had since I had shingles a couple of years ago, which is, for me, is the maximum pain I've ever had. And this was just before an operation. I don't know that my new score was high or not, but what if the nurse looked at me and thought, I'm concerned about this patient, but the new score is low? Would she or he be discouraged or encouraged to speak up, or what would happen in that case?
Oh, maybe I can take that. The situation where there is clinical concern from any clinician at any level, we don't use the news score as the be-all and end-all. We would always encourage any clinician who has a concern to escalate that concern if it's beyond what they can cope with themselves. So even if the news score is low, that should not be a reason to not ask your superior for some help.
Yeah.
Okay.
So it's not in the absence of judgment. Judgment is king,
Okay.
always. And news is just an adjunct. But what you've got to remember is not everyone has the same level of clinical judgment as everyone else. And, you know, it's about recognizing someone who has really bad physiology and making sure you get them to someone who knows a bit more and is a bit more experienced sooner rather than later.
Yeah.
And pain is an entry point for all deterioration pathways. So
Okay.
across Wessex, our 5 million population, we have a consensus guidance on deterioration escalation that revolves around having a bad news and gut feel clinical judgment, but pain, extreme pain being one of the criteria.
Okay. I'm somewhat reassured. So have you considered doing a baseline News 2 and frailty scoring in care home residents to help plan for management in potential deterioration solutions? So who'd like to tackle that particular question?
Like. So yeah, we happily, our Restore 2 charts that we've used across the whole of Hampshire have that built in. So monthly News 2 scores for every single resident, essentially. So we know what the baseline is, and we can assess when someone has gone off. We've extended it beyond that to actually all general practices as well. So within CHI, which is our electronic system, our digital regional system, we have baseline observations that are put in by our GPs for blood pressure near universally, and increasingly oxygen saturations, which is really, really useful. But for the care home staff, patients particularly, we know their baselines. And interestingly, we think that everyone in a care home situation who's frail is going to have an elevated News 2 score. You know, it's just part of human nature, we assume. But actually the reality is the vast majority, I think it's about 75% score 0 and about 85% score 0 or 1. So actually the vast majority don't really trigger normally.
Well, let's move to another question. Have you seen, this person has seen, that this is Christine Cook, seen that news is not calculated correctly quite often. How can we improve this?
Well, there are some very, very useful apps out there now. If you just go onto your Google Play or to your iPhone store, you can download an app for free, which will calculate news for you as you pop the figures into it. Very, very simple.
You got a camera? No, not sure where that camera is.
And what's the app called, Matt?
Well, if you just Google News 2 in the App Store or iOS, you come across this one. I mean, I'm not a shareholder in this particular company, but it's free. OCB Media, News 2 app. I use it every day and to help with my rubbish maths. So I'd encourage all of you, if you're trying to calculate the news, use something that helps you do it, because we know we're only human. We can make mistakes.
Yes, and that one is free, but if you pay £2, you can have it ad-free. So it's well worthwhile the £2.
They say they're not shareholders, but...
Yeah, John might be.
So we have another question comparing news to SOFA score. So international consensus on defining and monitoring sepsis is by the SOFA score. Given its greater, and it's moved, simplicity and usability, what about using the Q-SOFA?
That's a great question. And, you know, I'm a big fan of simple. And when Quick SOFA first came out, I was really hoping it would be the answer. I really was. Unfortunately, it isn't. And its limitation is basically it only looks at 3 parameters and news looks at 7. As a result, the ROC curve greatly favors news. So we should be particularly proud of news as a country, because it is the best early warning system and the simplest that's out there. The only one that comes close to competing with it comprises of over 100 variables, including blood results from America. And the beauty of news is that it can be done in a GP surgery. So although I appreciate it's not as simple as 3, what we found with Quick SOFA is that it misses a lot of people who die. So it's not quite as good in terms of the thing we use, which is a ROC curve, which is how we assess the sensitivity of a test against the specificity. So because of a limitation of it, we went with news. And what you find when you look at a news level of aggregate score of 5 and you compare it with a Quick SOFA of 2 or more, is that actually the level of news 5 picks up all the patients that die with a Quick SOFA of 2 or more, as well as a few patients that Quick SOFA misses out on. So it's just better.
Thomas, John, would you like to add to that at all? Or?
Yeah, I mean, there has also been talk about the use of a single parameter scoring 3 on news as a trigger, and that also is not as good as using aggregate scores in news.
Yes.
The validation of news has gone back to way before 2012 when it was first published by the RCP, and there's an awful lot of work gone into understanding the levels of physiology that trigger the score at each level. So there's a lot of science there, and really we do know that news is better than anything else out there that's actually usable in real world.
And are you aware of NICE guidance that's changed to accept the use of news? And I know that's a bit controversial, but CG51 went down this extreme observation red flag type approach, but there's no evidence to support it. So, NICE essentially have gone with news for the first time in their history. So, yeah, a soft launch, but interesting nonetheless.
Okay, the clock is against us, and I think we need time to make sure that people arrive in without bursting into the scene while we're still chatting and talking. So please express some thanks and join me in thanking Tom, Matt, and John.
Well done.